Mike Gibson, HS Kim, coming to you live from ACC 2026. And Dr. Kim, we are talking about the 10-year follow-up from the host exam study, a trial comparing monotherapy of aspirin with clopidogrel. So talk to us about the results in your previous presentations and how the 10-year results add to that.
Okay, good morning. I'm HS Kim from SNU Hospital, Seoul, Korea. The background of host exam RCT is after PCI, guidelines recommend indefinite maintenance of single antiplatelet therapy after initial 6 to 12 months of DAPT. Thus, aspirin is the most widely used standard antiplatelet agent, but clopidogrel is recommended as an alternative strategy. But no trials has addressed which agent may be the optimal choice during the chronic maintenance phase after DS implantation. About 30 years ago, there was one RCT, such as Capri trial, compared clopidogrel versus aspirin. 30 years ago, it was published in Lancet. At that study, clopidogrel was better than aspirin in terms of reduction of vascular death, infarction, and stroke. But at the time, the patients included were heterogeneous, not only BMS PCI, but also other ASCVD patients. And price of clopidogrel was too expensive at that time. Thus, the results was not translated into guideline change. Thus, 10 years ago, I started host exam RCT about 13 years ago. The objective was to compare the efficacy and safety between aspirin versus clopidogrel monotherapy as a chronic maintenance therapy in patients who received PCI with DS. Our hypothesis was clopidogrel will be superior to aspirin in terms of patient-oriented composite outcome, POCO. That includes all death, infarction, stroke, ACS readmission, and major bleeding, BARC, type 3 and 5. Key secondary endpoints include thrombotic as well as any actionable bleeding. Thrombotic composite endpoint include cardiac death, non-fatal myocardial infarction, ischemic stroke, ACS readmission, and stent thrombosis. Thus, we enrolled about 5,500 patients from 37 centers in Korea who were event-free under DAPT for around 12 months after PCI. We randomized them into aspirin monotherapy versus clopidogrel monotherapy. And then we reported first results at 2 years of host exam RCT. At 2 years, clopidogrel was better than aspirin in terms of POCO, patient-oriented composite outcome. 7.7% in aspirin, 5.7% in clopidogrel. About 30% risk reduction with clopidogrel than aspirin in terms of POCO. Thrombotic endpoint also reduced by clopidogrel. Risk reduction is about more than 30%. Bleeding, unactionable bleeding is also reduced by clopidogrel. That was 2-year results. But this regimen is indefinite, lifelong treatment after PCI with DS. Thus, 10-year results is very important for us to recommend all the physicians in the world. That's the reason why we pursued 10-year follow-up.
And what did you see?
Yeah, we meticulously followed for 10 years. The follow-up rate is about 93%. And in this cohort, baseline profile, 1/3 is diabetes. And CKD is about 15%. Previous MI is about 15%. Previous CVA is about 5%. Stable, 25%. 75% were ACS patients. And depth at randomization point is mainly clopidogrel, about 80%. The 10-year results is dramatic. POCO was about 28.5% in aspirin, while 25.4% in clopidogrel. Hazard ratio is about 0.86. The risk reduction of POCO by clopidogrel is about 14%. We compared NNT, number needed treatment, to reduce one POCO. That was about 51 patients at 2 years. That was decreased down to 33 patients at 10 years under ITT analysis. Thrombotic endpoint was also reduced by clopidogrel, and any actionable bleeding is also significantly reduced by clopidogrel. All death rate is similar each other, around 12%. The main driver reduction of thrombotic endpoint was a stroke. That was 4.6% in clopidogrel versus 6.4% in aspirin for 10 years. Hazard ratio is about 72%. Another main driver between two regimens is major bleeding. That was about 5.6% in clopidogrel, 7.7% in aspirin. Hazard ratio is about 71. Thus, ischemic stroke or stroke and major bleeding is significantly reduced with clopidogrel than aspirin. Among 100 patients, about 77% of patients maintained assigned treatment for 10 years. Thus, we were able to do PP analysis, per protocol analysis. In this analysis, the difference more divergent than ITT analysis. 10-year POCO in aspirin was about 30%, while it was 24% in clopidogrel. Thus, we calculated NNT under PP analysis. That was 45 patients at 2 years, 24 patients at 5 years, and now 17 patients at 10 years. Thus, we can see the progressive divergence of the benefit of clopidogrel monotherapy than aspirin.
Wow, amazing results, Dr. Kim. Why aren't more people using clopidogrel monotherapy?
The reason why more patients are prescribed with clopidogrel?
Well, personally, I think we should be using more clopidogrel, but people are still using aspirin. How do we get them to switch to clopidogrel?
Yeah, the most important thing is to propagate this knowledge into widely physicians in the world, and with the underlying biologic action mechanism. Aspirin is as well known to be an inhibitor of cyclooxygenase. Thus, it not only inhibits thromboxane synthesis, but also it inhibits prostacyclin, as well as many prostaglandins. Thus, aspirin is not a strong antiplatelet agent.
Yes.
Simultaneously, it exerts many non-specific side effects by disturbing synthesis of other prostaglandins, thus resulting in mucosal barrier disruption that may cause GI bleeding or even intracranial bleeding. That is twofold higher than clopidogrel. But clopidogrel is a very specific drug. that just pinpoint inhibit P2Y12 receptor on the surface of platelet. Thus, it is very strong against the platelet-driven thrombosis, but it has not any other effect. That's the reason why clopidogrel reduce not only thrombosis but also bleeding.
Bleeding. Yes. Wow. Great job, Dr. Kim. Thanks for sharing with us today. Congratulations on 10 years of follow-up in 93% of patients. That's tough. That's great. Thanks for joining us today.
The final notice is this paper will be published in the Lancet the same day when I present the results in LBCT of ACC. That was March 29th this year.
Congratulations, and please share your slides with us so we can propagate the message worldwide.
Thank you very much for having
Thank
me.
you, Dr. Kim.